Hello. I am going to be doing my presentation as if I am an athletic trainer and you guys are other healthcare professionals, specifically physicians and nurses located in emergency departments, such as an emergency room or an urgent care clinic. Let's begin. I'm presenting on emergency invasive procedures and athletic trainers. And what we're really going to be talking about today is how implementing some emergency invasive procedures into athletic training can greatly benefit the athletes that we see. So think about it. As other healthcare professionals, how do you treat things such as heat stroke, anaphylactic shock, and even diabetic crisis? All of these things require some sort of treatment of an invasive procedure, whether it's administering a medication via a needle or a syringe, or it's IV fluids for rehydration. We're going to be talking about a lot of this stuff today, so let's get started. A quick overview. Athletic trainers are the first line of healthcare for athletes everywhere nationwide. And athletic trainers currently in Pennsylvania are not permitted to perform invasive procedures under any circumstance, and it is stated by our Practice Act. However, performing certain emergency procedures could greatly benefit our athletes and prevent life-threatening situations from turning catastrophic. As athletic trainers, we can make your jobs as physicians and nurses easier and better by getting to these athletes first with a better line of emergency care. So that way, once you're seeing them, we've already increased the chance of a better outcome and decreased the chance of a catastrophic one. Moving on to our Pennsylvania Athletic Training Practice Act and also the related domains of athletic training. In our Pennsylvania Athletic Training Practice Act, it tells us that athletic trainers will provide a certain number and kind of athletic training services. Further in the document, it does say what types of services we will provide, but there is a specific part that says the term does not include surgery, invasive procedures, or prescription of any medication or controlled substances. That little part right there about invasive procedures really hinders us in our best form of emergency care and treatment. Working under a supervised physician. So we get direct orders from a supervising physician that tell us what we can and can't do with the athletes that we're seeing. We work under their license, even though we do have our own license, but our poor judgment and our poor practice can reflect on a supervising physician if a lawsuit or a governing body feels that the supervising physician should have known better that our poor care was happening. Because that is the way it is, there is the ability for supervising physicians to allow athletic trainers to do certain emergency invasive procedures, and a supervising physician can really help us get this passed. There are 5 domains of athletic training, but we will really be focusing on 3, primarily just one, but the 3 that we will talk about is injury prevention, clinical evaluation and diagnosis, and immediate care and treatment. All 3 are crucial to good emergency treatment. Injury prevention is half the battle. We want to stop the emergency situation before it can even begin. So athletic trainers are trained and qualified in injury prevention. So we are able to stop those situations from happening by preventing and decreasing risk factors. Next is clinical evaluation and diagnosis. Athletic trainers are also trained to see a situation unfold and to be able to quickly and efficiently evaluate the situation and diagnose the problem. In an emergency situation, this is crucial. We need to be able to say, this person over here is in this situation. Here's our immediate emergency treatment, because emergencies cannot wait. Lastly is the immediate care and treatment. Once we've gone through the diagnosis and we know what we're dealing with, we are trained to care and treat an athlete immediately and in an emergent situation to the best of our abilities. However, there are some things in certain situations that would be extremely beneficial to athletic trainers and their athletes more specifically that we are not allowed to do now because they are considered invasive procedures. I will be talking about 3 key points in this presentation: heat stroke and dehydration along with IV fluids, anaphylaxis and the use of EpiPens, and diabetic coma using insulin and glucagon to combat hyperglycemia and hypoglycemia. Starting off with heat stroke and dehydration, we can look at the Corey Stringer Institute. Heat stroke is when the core temperature of the body reaches 104 degrees Fahrenheit or 40 degrees Celsius. That is usually taken by a rectal thermometer, as it is more appropriate and more accurate. You can start to see signs and symptoms such as a rapid pulse, a low blood pressure, quick breathing. It's like all other shock symptoms. The body is shutting down, it is too warm, and it cannot function properly. This, if it is not treated and cared for properly, will prove fatal in a lot of circumstances. So if we look at the Corey Stringer Institute, I have pulled up their treatment section. If you look at the website here, it is extensive. And this is really what athletic trainers use as the gold standard of treatment for heat illnesses. You can come into their emergency conditions tab, come under to heat illnesses, go to heat stroke, and then we are under treatment right now. But you can also look at prevention, risk factors, recognition, return to play, and also other resources when learning more about heat illnesses. Looking specifically at the treatment, this is what athletic trainers nationwide should be following as the gold standard because it is recommended by the NATA. Removing all equipment and excess clothing. This is very important when it comes to athletes such as football players and lacrosse players who have those big shoulder pads and they have helmets that are only keeping that heat in and helping to raise that core temperature. That becomes extremely dangerous, especially in preseason during the summer for football athletes. They've just started playing. They're not in great shape. They're not used to the weather and acclimatized to it. And now they're putting all of these heavy pads on and doing more running and exerting more than they have in the past couple of months. Those are all really big risk factors for heat illness. So you see a lot of heat illness in football. Next is to cool the athlete as quickly as possible within 30 minutes. Ideally, this is with a ice water immersion. So you're going to dunk them in a big tub full of ice water to try to get their whole body immersed in water. So it's going to cool down very quickly. Unfortunately, some schools don't have access to things like those big tubs where you can put big football players in or even small cross-country athletes in. They don't have something that's that big that they can hold it in. So if that's not able to be performed, then you're going to use cool rotating wet cloths, ice packs to cover as much of the body surface as possible. After making sure that they've maintained consciousness, airway, breathing, circulation, you want to cool them to around 101 to 102 degrees, and then they are prepared for transport. After you have started cooling them, that is when you call 911, and you do not transport until their temperature is under control. However, what the Corey Stringer Institute doesn't talk about is dehydration and its part in heat illness. Dehydration is a major problem with heat illness because you've gotten to the point where you have exhausted the excess water in your body and you are no longer sweating. If you are no longer sweating, the body has lost one of its primary ways to thermoregulate and to cool the body. That is where the use of IV fluids comes in. It would be extremely beneficial for athletic trainers to be able to insert an IV into an athlete suffering from heat stroke because it is one thing to cool them, but if they do not have water in them to keep their body cool, you are going to go back into heat stroke after you take them out of that cooled environment. IV fluids can help for rehydration, which increases the cooling ability of the body. It is extremely important to get these athletes rehydrated. And one of the things that an athlete is going to get the treatment at an emergency department is an IV fluids. This is where timing becomes an issue. Timing is extremely important in every emergency situation, especially in heat stroke. So say, for instance, you are at a rural high school, you just started preseason football, one of your athletes goes down, you check the temperature, he's at 104 degrees, and you know you have to start implementing these recommendations from the Corey Stringer Institute. You call 911, you activate EMS. However, your closest hospital is 30, 45 minutes away. You don't have a closer emergency department than that one that's too far away. You now have to make sure that that athlete is maintained a cool body temperature until they get to the emergency department. And within that ride along an ambulance, they may not stay in that good optimal temperature range. They may spike again. If athletic trainers were allowed and taught how to insert an IV with a saline drip just for rehydration, you can send an athlete along with a rehydration. And now you've sent them with replenished fluids and a way to cool their body again. The way to work this into an athletic training educational curriculum is to look at the IV therapy training that EMTs and EMS have. EMTs are taught how to insert IVs, and they take EMT intravenous therapy courses. And I do have another website to look at. This website here shows the course description, course overview, the objectives, the hours, and everything like that. This is something that could be very easily implemented into an athletic training educational program. This is very common to what a clinical program is. So you have hours in the classroom learning how to do the trade. Then they have a field internship rotation where they practice the trade. After they have completed a minimum of 10 IV insertions, then they are able to sit for a practical exam and a written exam. Once they take the practical exam and the written exam, then they are certified and allowed to use this IV therapy. If we as athletic trainers were allowed to do these types of classes, it would be very easy to work it into an athletic training program, and it also would be extremely beneficial. Moving on to anaphylaxis and the use of an EpiPen. Anaphylactic shock is, as you know, a severe allergic reaction. It can show, once again, is another sign, it is another type of shock. It can present with low blood pressure, an increased heart rate, quick breathing, the airways constrict, the body starts to swell, and you can also see other common allergic reaction type signs and symptoms such as hives, red rash, pale skin, itchiness, lethargic. So if you have an athlete on a field who is stung by a bee and you know that they have a allergy to bees, they have given you an EpiPen to keep just in case they need to use it. However, this reaction happens very quickly this time and they have been thrown into anaphylaxis. But you get to an athlete at the point where the athlete cannot assist in the administration of the EpiPen. Legally, athletic trainers currently are not allowed to administer an EpiPen to an athlete in anaphylaxis. They can only assist the athlete in administering it themselves. But if the athlete can't administer it themselves, now you're stuck in a problem because you don't want to step out of your scope of practice and risk a lawsuit, risk losing your license, risk losing your job, but you need to save this athlete's life as anaphylaxis can be fatal. So you should be able to use the EpiPen. Once again, timing is important. You may not be able to wait for this athlete to be transported to a hospital. Once again, if they're at that rural high school, they get stung during football practice and they've got a 45-minute trip, they might not be able to make it to the high school. If we are able to administer the EpiPen for them, they have a greater chance of making it to the hospital with a better outcome. Lastly, the use of EpiPens is taught during athletic training courses in universities. Athletic trainers are taught how to properly administer and use EpiPens. So there is no reason why we should be taught how to use them, but not be allowed to use them to help our athletes stay healthy. Next is the diabetic coma, and we're going to focus on insulin. So we're going to focus on hyperglycemia, which is greater than 180 milligrams per deciliter of glucose in the blood. And I have a short video, which is pretty simple, but it is a very good video for diabetes and athletes.
This important information is provided by Safe Sports Network, a nonprofit dedicated to youth sports safety. For the person with type 1 diabetes, the body is not able to produce insulin. This type requires careful monitoring and injection of insulin into the body to maintain proper blood sugar levels. In type 2 diabetes, the body can make some insulin, but either doesn't make enough of it or it doesn't use it properly. An athlete has greater energy demands than a person at rest. He or she uses glucose faster. Blood sugar drops quicker. When blood sugar levels become too high or too low, the athlete can become shaky, vision can blur, speech may become slurred, or he or she can appear lethargic or out of it. Those blood sugars must be monitored much more closely to prevent sudden drops or spikes in blood sugar levels. Type 1 diabetes requires careful daily maintenance of blood sugar levels. Insulin is injected into the person to bring sugar into the body's cells, either if the blood sugar level is too high and or after eating a snack or meal. Sugary snacks like orange juice, cookies, or even glucose tabs can be used to briefly elevate blood sugars when the levels drop too far. Athletes are often able to recognize when they are feeling hypoglycemic and should immediately test their sugar levels if they're feeling any symptoms. Some athletes have automatic pumps that constantly measure blood sugar levels and pump in insulin directly to the body. Type 2 diabetes is treated and managed through periodic testing, diet modification, and medication. A person with uncontrolled or undiagnosed diabetes can display any of these signs: excessive thirst, frequent urination, extreme hunger, blurry vision, weight loss despite eating more, and slurring speech. If you or your child have any of these symptoms, contact your doctor to be evaluated. Long-term uncontrolled diabetes causes significant damage to your body tissues. For example, blindness is one of several possible long-term effects of unhealthy sugar levels. The earlier diabetes is diagnosed, the easier it is to learn how to manage blood sugar levels and therefore stave off these long-term side effects of diabetes. The National Athletic Trainers Association has created a management plan specifically for athletes. It includes strategies to help keep athletes with type 1 diabetes safe. These include what to pack to do testing on the sideline, what to pack when traveling to away games, and what signs and symptoms to watch for when blood sugars get too high or too low. To learn more about diabetes, make sure to check out the links below. And make sure to visit our website at www.safesportsnetwork.org.
Okay, back to the presentation. So please remember that athletic trainers do work specifically with athletes, and diabetes management is slightly different for athletes than it is for non-athletes. So going back to hyperglycemia, we all know what it is, over 180 milligrams per deciliter of glucose in the blood. It can present with an increase in urination, an increase in thirst, fatigue, nausea, and the most prominent sign and symptom would be a fruity smelling breath. It takes diabetic athletes need to be extremely diligent in their treatment, and lack of diligence can become catastrophic. They are constantly going between meals, practices, rest, some more practices, another rest, lifting, cardio, you name it. They do several different types of activities during the day, especially during their in season. So it is understandable. Sometimes athletes make mistakes, and sometimes their glucose levels go overlooked and they're not quite sure where they're at. They miss a measurement because they're rushed and on their way to practice. And unfortunately, that slight mess up is going to cause a problem. So we should be able to treat it to the best of our abilities. If an athlete has eaten too much and taken in too much sugar and their glucose is way above what it should be, even with exercising, they're not going to be able to bring that level down. They're going to be in a state of hyperglycemia. If they really overdo it, that can become a problem. And it is a less rapid onset, but it is still an emergency. The ideal glucometer measurements before activity for athletics is somewhere between 100 and 180 milligrams per deciliters. If they are way above that, like I said, and they might not be able to come down. Again, timing is important. It can be fatal if there's not a quick response and if there's already started to become a problem. The other issue with this is that insulin is a drug. It is a medication. However, we would not be prescribing it. It would be prescribed by their physician, and the physician would be directed on how to use the insulin and how to inject the insulin, and only in an emergency circumstance. So once again, it's the same thing that we do with every other thing in athletic training. We are working under a scope of practice provided by a supervising physician. It would just be something that would be added by a supervising physician. Going on to the other side, hypoglycemia and diabetic shock is a glucose reading of less than 70 milligrams per deciliters. Now, this one has a very rapid onset usually. There can be mood changes. They can become irritable and fidgety, shaky, sweaty, weak. It can result in seizures or convulsions, and ultimately they could even become unconscious. Because it is a rapid onset, it requires a rapid response. And sometimes one cookie or a sweet will not do it. So an injection of glucagon, once again, under the prescription from a physician and under the direction from a supervising physician, would be extremely beneficial to these athletes who are struggling this diabetic crisis. A theme here, timing is important. It needs to happen quickly. If they might not be able to wait for transport, once again, you can't always wait for an ambulance to get to the hospital. These are things that we can control as they are happening on the field and on the plant and in the competition area. And then legal ramifications. So if athletic trainers step outside of their scope of practice, outside of their practice act, they can be subject to lawsuit, job loss, or even a revoking of their license. So a lawsuit makes sense in cases like the Corey Stringer case, where a football athlete was dehydrated and went through heat stroke, and the athletic trainers did not treat him to the best they could, and he wound up dying. Next, it's still understandable for the NFL and the concussion allegations that are going on. If the NFL athletic trainers are not managing concussions appropriately and allowing these athletes to play, even though they should not be playing, it is understandable why there are lawsuits coming up. But there should not be lawsuits coming up for athletic trainers who are doing what they should be doing, who are doing the best to save a life. The best to save a life would be including the use of these emergency invasive procedures. it's going to increase good outcomes, and it's going to save more lives. In conclusion, athletic trainers should be taught and allowed to perform these emergency invasive procedures to increase good outcomes and to decrease risk of catastrophic injury. And here are my references. Thank you.